So we did have a few questions emailed in to me, but I'm happy to start with that question. Again, bearing in mind that Helen's giving a talk later on. So did you want to speak to that question briefly for us, Helen?
It depends on whether you've got a recurrence after your 6 months of Tumour or not. In the States, they did a trial giving twice as much Temodol as we normally do, and we made them twice as sick, but we didn't improve survival. So the standard 6 months of Temodol is standard. Giving more doesn't seem to be any better. It certainly increases toxicity. So if someone is pretty much in remission after the 6 months of chemotherapy, we stop. Some people think more is better. In the States, some people never stop. So you could stay on Temodol until you relapse. And there's no right or wrong.
So my question was more about what are the treatment options following that treatment?
There's absolutely no standard of therapy for relapse disease. We sometimes have clinical trials open that are suitable. Clinical trials open and shut. Some have entry criteria. I mean, at the moment there's some trials open for people with certain targets. They open, they shut. And if there's not a lot of toxicity, they may go on to a larger phase 3 study. But there's absolutely no standard of care. So it depends on your oncologist as what their favourite recipe is, rather than there is a standard of care for relapse disease.
So it sounds like there aren't treatment options commonly used, there are just options available.
There are options available, but there's no flat recipe.
Yeah, I think that's actually one of the main focuses of research. Kerry, I don't know if you want to comment, but it's usually at that stage that we're starting to see most of the trials come in. I think that the first part of the journey, if you like, that Jacob described with surgery and radiation, and then the Stupp protocol's reasonably, because it has been such a significant advance that most people are following that, and the focus now is at the time of relapse. And I think Helen summed it up quite well.
So Helen's point is perfect. When there is a tumour recurrence, sometimes there may be the option of further surgery.
Sorry, both your microphones seem very...
Can you hear me?
Can you hear me?
So certainly there's no absolute standard. I think it's well established when we find out that we have a de novo GBM, what we should do. But when it grows back, well, what's the best thing to do? There are options, as Helen has said. One option may be further surgery. One option may be to change the type of Temodol administration. One option may be to change to another chemotherapy. One option may be, if the tumour has arisen elsewhere in the brain, to give more radiation. So there are options, but there's no one option that we know at this point to be 100% correct. So that's why there is a lot of variability between different centres. Now, everybody is trying very hard to individualise the treatment so it's right for that particular person, but the options are pretty wide-ranging.
I think that's probably true as a surgeon, just to say that that's also the case with repeat surgery, is that the philosophies vary quite widely in terms of when, if at all, second, third, more operations are appropriate for high-grade gliomas. So again, that's a very, surgery as one of those, if you like. Other treatment options is again, there's no sort of hard and fast guidelines. We had a question at the back.
Yeah, this one's for Helen. I was just wondering whether there had been any more update on treatments for IDH1 positive tumours. I know there's some research going on, and I think phase 1 trials going on in the US doing something to do with 2HG or 2GH or something.
Look, it's all gossip. And it's really hard to get the gossip out of the confidentiality agreements that when Americans sign them, they very rarely gossip. they started some phase 1 trials with an Argos drug. There's a company called Argos who seem to have an IDH2 inhibitor, which is working brilliantly in people with IDH leukemias. And we all thought with IDH1, which is a slightly different genetic problem, and which we see in grade migration gliomas, that we were on a winner. And my feeling is that it doesn't cross the blood-brain barrier, and they've gone back to the starting line, and they're giving the drug and then reoperating to see if the drug's getting in. So they initially started as a normal phase 1 trial, which is give 3 people a dose. If they haven't hurt them, give the next 3 people more, and they weren't seeing the responses they hoped for. And now I've heard that they're actually going back to giving people what they think is a safe dose for 3 or 4 weeks, and then taking them to theatre and seeing whether they're hitting the target and they're actually inhibiting the enzyme that they want. The other thing that's going on that's really annoyed me is that the Germans have a vaccine against IDH1, and they've taken it into the adjuvant phase of treatment. And we know people with IDH1 tumours do really well. So I'm going to be long dead and buried before we have a result from those adjuvant studies, because they will give everyone this vaccine at the time of diagnosis, and they're already surviving 10 plus years. So it'll take a long time to accumulate the patients, and if it's working, another 20 or 30 years to see if there's a separation in the curves. It's a vaccine on trial at the time of diagnosis of your IDH tumour right up front. Our big hope is that Duke looks like they've got an IDH vaccine, and they may be a little more sensible about the way they use it. So we're hoping that they may come up and use it in the relapse setting. So we'll start seeing it in patients that have got IDH tumours in the relapse setting, and we'll get some idea if it works or not. But I've had a number of fights with some German investigators, and it hasn't worked.
And we all thank you for it. Any other questions? There's a couple of questions down the front here, sorry.
Thank you. Hi, my name's Philly, and I've flown in from Melbourne this morning I actually came to try and get involved and support the forum because I think it's fantastic. However, my husband has I actually like the picture of that cloud up there because that's what my life's been. I call my husband's brain tumour a cloud because it's benign, but it's a schwannoma in the jugular foramen of the brain, which is a very difficult, I can tell by your faces, because that's the reaction we get every time we mention it to somebody. We're at the stage now where it has been debulked in 2012 when we found it. It's progressively grown, and I am racking my own brain because I like Dr. Fairhall's quote, find a clinician who is passionate. And we do have clinicians who are passionate. However, we've got discrepancies between ENT and neurosurgeons, and I'm stuck.
I think maybe Jacob, if you wouldn't mind kind of commenting on the terms benign and malignant, because when we use those in the brain, it's sort of in a bit of a different context to...
Jono, you're absolutely right. Benign is, in a sense, a bit of a misnomer. We talk about benign brain tumours. Can you hear me still? Good. We talk about benign brain tumours because that's their biology. Okay, they don't spread to other parts of the body. They don't tend to invade the brain itself. But of course, they're not really benign, are they? Because they can occur in critical parts of the brain, parts that can't really be accessed with ease with surgery. And these tumours, although they're benign, they continue to grow. Okay, so although we talk about benign tumours, in no way does it mean that it has a benign effect on the people in whom they occur. Malignant tumours, they tend to infiltrate a bit more into the brain and spread more widely, and not in a discrete fashion, but in a very sneaky fashion. But benign tumours can be very difficult to deal with if they're in a critical location. Now, the jugular foramen, for everybody in the room, is a little space at the base of the skull. It's a space through which some critical nerves pass down from the brain into the face, the tongue and absolutely, and in the throat. And because this space is very tight, even though this tumour is benign, it can push on those nerves. It can be very difficult to tease this tumour away from those nerves safely, so it can be acting in a less benign fashion, in a sense. In terms of the discrepancy between the neurosurgeon involved and the ENT surgeons, it's difficult to comment on an individual basis, I've got to say. We can, I'm sure I speak for everybody on the panel that with individual advice, it's tough for us to give that, but we can certainly have a quiet chat during any recess or lunches that we have.
And do you want to, Sue, maybe comment on other treatments for, say, schwannoma and any of the other sort of traditionally benign, the roles of radiation, for example?
Sure. So I guess, as you said, passion usually comes together with expertise because they drive and that they sort of motivate one another. And obviously in Melbourne and obviously cities around Australia, there is, you know, both amazing expertise. And I think the situation that you shared, you know, absolutely such a rare situation where you really need a fantastic multidisciplinary specialist team, as you mentioned, base of skull surgery, ENT surgeon, neurosurgeon, and a specialist radiation oncologist, you know, to really help make a decision. And it is hard when you're having specialists with a different perspective, and that just means that for such a rare situation there is no right answer, and each option we have to weigh up clearly the high risks but also the benefits of which treatment. So as it relates to radiation, of course, as Jacob highlighted, there are some very specialised targeted techniques, stereotactic techniques that can really sculpt to treat the tumour in that sort of location, obviously targeting the tumour very specifically with the ability to maximally protect or shield critical structures, so obviously the brain adjacent and the adjacent blood vessels and nerve structures. So it's really about, as you said, that personal drive to find the right team, the philosophy that you agree with as a family, and making a decision that's an informed one that ultimately you feel comfortable with. And that's very difficult. But you know, yeah, we're happy to talk about it also after the session.
And well done flying up from Melbourne and considering getting involved with support. Everybody, consider that, please.
Okay, and I think, sure, go on.
My question's probably to Dr. Wheeler. In relation to drugs, as you know, you probably get a lot of people asking you about different drugs when they have people or relatives that are suffering from a brain tumour, and there might be a lot of gossip around. But recently, having a relative with a brain tumour, but recently it was drawn to my attention of an individual, a gentleman, who was given a drug and took the drug, and it was quite effective in reducing his brain tumour from 13 centimetres to 9. And that drug was Dostonex, or carbaline, which is not known to treat, its treatment or its action is not specifically for brain tumours. However, I'm aware that it does treat pituitary gland problems, and to reduce prolactin and similar sort of things. However, this gentleman was given it, and it reduced, and he's been treated with it for 10 years. And my question is, and so we bring these sort of stories to the attention of patients and their carers in the hope that it might help along the way, and is there an opportunity for that person suffering to have this drug or that drug, that sort of thing. My question is so like the doctors get these stories and are wondering about different drugs. So my question is there a pathway for these non-specific drugs to be looked at and may have the potential to be provided to individuals when they're not specifically... No, I don't know whether this has ever been on a trial or anything. Yeah, so...
I mean, there's a couple of websites around, and I was directed to that. It was last Friday night, where there's a website. It's called off-target use of medication, which are currently on the PBS. Mebendazole, I think that's for liver fluke, an antibiotic, and I think there's a list of about 30 off-target drugs. And so what you do is you get this genomic map of different pathways that could be involved in tumour development, and they map them out, and they say, well, the off-target drug A, drug B, drug C, going down the list could affect this particular pathway, and we'll give you this list, and if you put A, B, C, D, F, G and keep going together, or one or another or something, you may well fix the tumour. And they can look quite legitimate. I was emailed a list of about 10 drugs they wanted to give a child. And, you know, the website that I went to was claiming that they had treated 300 patients with brain tumours and had great success. My comeback to that is, well, if you have treated 300 patients with brain tumours, why haven't you gone out there, put their pathology on the list, put the list of drugs that you've given these patients next to it, told us what the side effects are, told us what pathologies is these, pilocytic astrocytomas are these, grade 3 astrocytomas are these, GBMs, what drug interactions have you got? And therefore, if I get the next pilocytic in my clinic, should I give them Dostonex, doxycycline and mebendazole? Should I give them marijuana, and, well, will their toes drop off and will their teeth turn purple if I put all that stuff together? You know, 300 cases for which the patients have probably paid $50,000 to $60,000, and you can't publish it. So I agree. I mean, I've seen so many anecdotal cases where people are desperate, and I understand why they're doing it. I would love to see the pathology. I'd love to see why, you know, this particular patient has responded. I'd love Kerry to get hold of that tumour, put it in the lab, find out why Dostonex works. And next time we get someone with that genomic anomaly, let's try Dostonex for them. But please let's share it with the world and not just anecdotally say, let's every GP please give Dostonex so everyone in the room has got a GBM, you know? Because that tumour might not have been a GBM. It may have, or it may have been a GBM. I mean, we don't get the path right now, let alone 13 years ago. And if this is so great, why are we hiding it? You know? And so I get a bit riled now with this kind of stuff.
So, Kerry, did you maybe want to just comment on if someone asked you if they had a patient who been put on an unusual treatment or a treatment for another reason, what you would see the process, like how you might analyse someone's tumour to kind of try and figure out why they may have responded?
Yeah, so what we do is we take a piece of that tumour and grow it and then test those tumours in real time on the cells. And so what you were just talking about is called a repurposed drug. And these repurposed drugs could be, you know, there's a huge amount of repurposed drugs out there that are just waiting to be tested. And, you know, drugs that have been used for multiple sclerosis or Alzheimer's disease or other elements of the brain could actually be effective in brain tumours, antidepressants, things like that. They're all called repurposed drugs. So what we're trying to do at the moment is test these in vitro, so in a culture system, and also put that in vivo, which is in an animal system. And then what we do is a phase 2 trial to actually test these drugs. And as Helen said, if we can actually match the genome to that responder, then I can go to the clinicians and say, look, you know, we can do this test and these drugs may be effective and move on from there.
We Helen briefly mentioned marijuana, and we did have a question emailed in about that. I was actually going to see if Kerry's done any testing with marijuana in the lab, or she's based at a university.
Personal interest, Jono?
Yes, look, unfortunately that comes under a class of drugs that we are not allowed to use unless we get a licence, because we don't trust the students.
Not your students though, Kerry. Kerry was my PhD supervisor. Now, Helen, is there any evidence with medical marijuana? It's something that comes up. I mean, we can make jokes about it all day, and I'm happy to. But if
I actually have it in my talk this afternoon because there's been so much publicity, and I think Mr. Baird's actually given about 7 or 8 million of government money to research it. But the one topic I wanted research was, does it have any anti-tumour effect, or does it make you feel better? And that's the one topic they've missed the mark on. If you're a rat and you have this clone of glioma called 9L, and you mix the 2 components of the 400 that are contained in a marijuana leaf in the right ratios, your tumour shrinks a bit. If you look at the different anecdotal reports on the web, and when I've looked and they put up the MRIs, they look like some very low-grade gliomas. There has been evidence that patient X in the States, tumour has shrunk a bit, but they do really look like low grades or pilocytics. But there's not, the evidence is very anecdotal. So as long as you're a Fisher rat and have got 9L glioma in your head, you're doing okay. And one component of marijuana is called CBD, and it doesn't make you high, and it's not what the guys are growing in the backyard, because it's not what the junkies want, because it doesn't make you high. Is actually being purified and sold by a company called GW Pharmaceuticals for exorbitant prices, and is in trial in the States for kids with 50 seizures a day. And some of those children are doing extremely well. So it's actually been separated, it's been trialled, and in some of the children with these specific seizure syndromes, like Tourette's, it is working, but it's not working for all the children. So it's actually been taken forward, and it will probably come as a seizure med for individual children that are assessed properly, and maybe some adults as well. So it's not in the scrap heap, but it needs to be properly tested.
Okay. Well, a couple of the other questions, it kind of comes back to what Barry was talking about earlier. One of the questions emailed to me was about a grade 2 oligodendroglioma that had been operated on twice, but not completely resected. Perhaps we'll just ask all the panel members what they think. So if you've if you've done a post-operative MRI, Jacob, and there's residual tumour and it is a second resection, or you've already got the pathology that suggests that it's a grade 2 oligodendroglioma, is there a circumstance where you'll reoperate acutely, or would you tend to watch that? What are some of the factors that make you make that decision?
Well, it really depends why the resection may have been skimped on in the first place, whether the area of residual tumour is close to eloquent parts of the brain. So I was concerned that...
Do you mind if we just sort of keep it pretty general to begin with? And that's fine. We can potentially come back to that, but I think it's just so that it's a bit more applicable to everybody in the room. Sorry to interrupt.
But it's a good point. With individual stories, there are going to be many, many different things that have gone on. But in terms of Jono's particular question, what do I do if I've operated on somebody, there's residual tumour, it's a grade 2 oligodendroglioma? Generally, I'd hope that the resection shows residual tumour because there's been a discussion beforehand about the aims of surgery, whether it's to aim for maximal resection versus to aim for complete preservation of neurological function. And to answer your question very simply, I'd put it to the patient after the surgery what the result of the MRI is. We talk about whether we've achieved the aims of surgery, and generally, but not invariably, we talk about whether there may be the option of further surgery, but probably we'd watch and wait to see if there's a change. Now that's with an oligodendroglioma. That's not really delving into the 9802 study from last year and whether there might be the possibility of adjuvant treatment, but it's a difficult question to answer because you have to have the discussion not in a forum but with the patient sitting in front of you.
And I think, you know, you talked a bit about awake craniotomy and the role for it, and I think this is a good example of where awake craniotomy may be useful. I'm much more of an advocate of awake craniotomy. That's my preference compared to Jacob. We know that, we've talked about it at length. I think that we're seeing a lot of data about complete resection of particularly low-grade tumours, and that the prognosis is generally better than when there's a subtotal resection. The question then becomes, what they don't compare in those studies are people who've had a complete resection but have neurological deficit versus those who have a subtotal resection who are neurologically intact. Because we know one of the key predictors of outcome in glioma of all grades is the Karnofsky performance score. That is how well you are from a neurological perspective and how dependent you are based on that. So I just think that's just a worthwhile kind of a good point to make in the context of this discussion. Sorry?
And that's the case with every tumour. It's always a seesaw between taking as much of the tumour out as is possible versus preserving function, between preserving the performance score. Hugh Defoe is trying to do supra marginal resections, where he's taking normal brain around low-grade tumours, and he's probably getting a survival benefit, but he's resecting to the point of deficit, and then some of the survival benefits probably lost because of the loss of the performance score. That's a seesaw and a tightrope.
Helen, did you want to comment on chemotherapy in that setting?
I mean, I have this really big problem because those patients we compare who can of gross total resection in historical literature is because they're in a great location. They're in the right frontal lobe where they can be taken out very safely, versus the ones that have got a bit left behind are not in a great location, and they have to have something left behind if you want to still walk and talk. So, you know, I know the surgeons kind of argue about the fact that you've left 2 millimetres behind, but I mean, the next thing is that these acute tumours, when you say oligodendroglioma, if you haven't got a 1p19q deletion, so you don't go the next step to the genetics, it's going to behave like an astrocytoma. So there's more to an oligo than just down the microscope. And the next thing that comes up is, you know, are you still continuing to seize after your surgery? So do you really need to go on and have further treatment now, or can you sit back, wait and see how it behaves? These tumours, if they're deleted, are exquisitely sensitive to treatment, but you may be at risk of some kind of deficit if you have a bleed. Is it in a very bad location so the surgeon couldn't go back if it changed later down the track? And they're very exquisitely sensitive to radiotherapy and chemotherapy. And in the old days, you know, the radiotherapists used to be pretty mean. You know, every tumour was a square box and they'd shoot from the front, shoot from the side, and you know, who cares what's in between? But these days, with very sensitive radiotherapy, people are coming out and with very little, with nothing, and they get rid of it. You know, they're 90% cured after just RT, or maybe that dreaded chemo. So, I mean, they're good tumours to have, and the risk of a deficit, not being able to talk for the rest of your life, is shocking. So I'm, you know, deciding who should go on and if there's not a gross total resection is something you really need to discuss. But if you've got to get one, it's probably not a bad one to get.
Yes, I would just add to the comments and say, as Jacob said already, the management of grade 2 glioma is such an evolving space and paradigm at the moment, and for both the specialists in the area and for patients and carers, it can be quite dizzying to work out what is the right sequence of treatments. And, you know, as a radiation doctor, believe it or not, I'm very unkeen to ever give radiation to a patient they don't have to. Particularly, we know that the low-grade patients are often very young, functioning well in life and in work, etc. And we want to do as much as we can to preserve that. So as it relates to radiation, the questions I ask myself are, how much has the surgeon removed safely? Where's the tumour location? How is the patient in terms of, do they have deficits or not? What is the genetic signature of that particular tumour? Has it been looked at by the right people that we have confidence in? And we'll hear about that more from Michael Buckland this afternoon, and Kerry, and just understanding as much as we can about the tumour, and then making a decision about radiation. As Helen said, it's a very sensitive, the oligo tumours are very sensitive to radiation, so that's great. So there is obviously a benefit, and controlling the tumour is our #1 priority, But we do know that with time, if one looks carefully, particularly with quite sophisticated neuropsychological testing, we do find that some patients who've had treatment with radiation do experience some cognitive change over time. Can't entirely blame radiation, because often patients have had surgery, they're on anti-seizure medications, and they're obviously older. So there are other contributors to changes in cognitive function over time, but radiation, I think, is one of them. And so we try and avoid treatment unless we think there's a clear benefit.
Kerry, do you want to... Oh, sorry, yeah.
Just one more very quick statement to echo Helen's statement. A few years ago, grade 2 tumours were pretty surgical. Okay, we'd operate and then we'd watch and wait. Now, Helen, Sue, much bigger roles to play. Okay, and probably commensurately less of a role for surgery in some situations.
So, Kerry, I might get you to comment a bit on, Sue used the term grade 2 glioma. We've sort of gone straight away from using the terms astrocytoma and oligodendroglioma, even in this little bit of a discussion. Maybe from a researcher's perspective, you might want to comment a bit on the grading system and some of the, the way that's changing to incorporate molecular tests and the WHO revision and things like that.
Look, I think with diagnosis to start with, I think you have every right to demand molecular testing done on your tumour, and very basic molecular testing. So particularly with oligos and astros, the first question that you have to ask, has 1p19q co-deletion been tested? If it hasn't, why not? Demand that test, because that will actually distinguish whether or not you've got an oligodendroglioma or an astrocytoma. IDH1 mutation testing, it's usually done at most centres, but if you don't have that result, demand that result. IDH1 mutations, the tumours do better than IDH wild type tumours. And again, that will interplay in your clinical treatment, because you have an IDH wild type tumour, the clinicians will be more aggressive with that tumour. We have some other tests that we can do now as well, called ATRX mutations. If you've got an ATRX mutation, you tend to be astrocytoma, not oligodendroglioma. And TERT mutations as well tend to be oligodendroglioma, not astrocytoma. So what I'm saying is that we can actually distinguish these tumours really well with molecular techniques now. Diagnosis between a grade 2 tumour and a grade 3 tumour. So grade 3s are termed anaplastic tumours. And the difference between those two types of tumours is actually the cell cycle, which Jacob was talking about this morning. And so we look for mitotic bodies. So if the anaplastic tumours are starting to grow, we can actually see that in the pathology. When they start to grow, that's when we term a malignant tumour. So it's not a low grade anymore. And so the treatment does need to become more aggressive. So I hope that's helpful and not confusing.
Yeah. No, I think it's good. The world, we talked about the WHO grading system that was last revised in 2007, and it was very much a histopathological diagnosis. Basically, look down the microscope, see what it looks like. But what we've discovered, we even really knew it then to some degree, but in the last 7 or 8 years in particular, is that tumours that look identical can behave wildly different for patient reasons, but also because they are just different tumours. So glioblastoma is not one disease, it's a number of diseases, and there's a whole bunch of research into that. And I know Kerry's going to talk about research this afternoon, and also Michelle Stewart in the breakout room, so I don't want to cover too much of what they will. But, I think that that's part of the reason that Jacob's excited about brain tumours, as am I, as are we all, is that we're starting to realise, being able to become more and more specific. Julie, did that answer your question? Okay, without it being... Yeah. And I don't know if Nicola's here. She sent in a question. Are you happy for me to paraphrase that, or did you want to pose it yourself? I don't mind.
I'll stick to the question.
Okay.
Yeah. Hi. I'm not sure who's the best person to answer this. I've been living with a brain tumour. Is that better? Yeah, I've been living with a brain tumour for 15 years, which was originally thought to be an astrocytoma. But again, pathologies have improved since then. So 15 years ago, I had radiation treatment and then watch and wait, rather anxiously, given we thought it was an astrocytoma. Had 2 children during that time and lived along. We've had a good life. It progressed 12 months ago, and I was biopsied, which was when we found out it was an oligodendroglioma, and I've just finished 6 months on Temidol. My question relates to deficits, a cognitive deficit, which I think was a gradual for me and became more noticeable last year when it progressed. And it's hard to know whether it was from the radiation or the tumour. But what I found difficult to find out last year was about what I can actually do for that deficit. And I started brain training in January with an online thing. So I've got cognitive deficit, which I've accommodated really well over the time. I've got quite a significant visual deficit on this side and really had to do my own research to find out what to do. So I started a brain training, which I've found excellent and has improved my memory, and it's in my parietal region, the tumour, so it's quite a varied sort of deficit. And I also found through the Stroke Association an online tool which trained my eyes to flick to the left and scan, which I found, and I no longer collide with things now. But what my question is I'm interested in whether the panel shares my optimism that I'm placing in the science of neuroplasticity. And if so, which is what the brain training is all about, and I know is what I'm getting the benefits from. And if so, what programs or professionals would you recommend, or do you recommend to your patients who's working in this area? Because me and I'm sure others don't want to just sit back and passively wait for what I think is the inevitable cognitive decline. And can that be delayed or even reversed?
Okay, so thanks for sharing that amazing experience, and you've highlighted several key things. So I'll just pick up where I left off my last comment to say that as your experience has demonstrated, with the advent of time we see, I guess, a manifestation of cognitive change. And so I think you talked about quite a significant period of time between first diagnosis and currently. And radiation techniques have advanced in that time, but there is still, we see the effect of treatment. As you also flagged, patients have often had other treatments, surgery, possibly chemo, anti-seizure medication. We're all a bit older. And it also depends, I think, on the innate functioning of that individual. Obviously, some people function extremely high level, and they actually, ironically, may notice the changes more than someone who doesn't function at such a high level, both in a work sphere and also everyday activity sphere. I'm not an expert in neuroplasticity, but I really loved your point about the fact that we have to look at solutions outside of our silo of oncology and cancer. And I think, from my own experience collaborating with researchers in brain injury, and as you said, in people who are specialising in neurodegenerative diseases, of which, really are affecting our society as a whole, obviously, I think there are some amazing solutions which are already there, and you sort of tapped into that, and I can see no reason why we can't translate those solutions into our sphere here. Because these people have been working, for example, brain injury have been working for many decades in patients who have cognitive change, behavioural change, and they have amazing tools and measures and interventions. And I do ask myself, why are we so far behind, in this oncology space? So I think we need to, both as clinicians, researchers, as a patient care community, really extend our reach and open our eyes and see, as you said, between the health disciplines, what solutions are available. And I think I don't have any specific ones, to mind. I think I want to bring the element of neuropsychology. There aren't enough of them. And of the neuropsychologists out there, some work in the private sector, some in the public sector, and they're quite hard to access for both clinicians and for patients and carers. But I think it's about that, as Kerry said, demand them. One has to have that drive and motivation to find those people who can do assessments, and those people often are very skilled at structuring an individualised intervention for a particular patient.
I'll just say I have been assessed and found to have significant cognitive deficit. But yeah, then there's been no progress from there or direction on now what to do. Yeah. So it's interesting you say that.
I think it is a two-edged sword, because sometimes it's very confronting to actually have in black and white, these are my deficits or changes. And so it can be both a tool to help guide a patient and their family, but it can also be very confronting, and one has to be careful with that document whose hands it gets into, because obviously our people are looking for employment and to go back into the workforce, and as I said, it can be a two-edged sword. So you're right, it's not perfect. I think it's just one of the tools we have at our disposal.
I'll just say, I mean, one of the problems is financing this retraining. I mean, number one is finding the people who are going to do it well, incredibly hard, and number two is that they're often very expensive. But I've seen some amazing examples over the last couple of years. You know, you can't fly a 747 after you've had a brain tumour. It doesn't matter if you're in remission. You know, the first thing you do is lose your car licence, you lose your plane licence, and certainly a commercial plane licence, but you can be a very functional instructor. And I've seen, and the other thing, I mean, I know a physician who is a very fine physician who has gone back, but they realised they had deficits. They went and did the retraining, and they reckon after the retraining they were better than before. They actually had the brain tumour. So I believe in brain plasticity, and I've seen amazing examples of improvement, but they were able to afford the help. And getting the help for in the general population is so hard.
I guess with the sort of variety of online tools as well to kind of help with this, it's it's something that could be useful. I mean, there's no question it's useful. It's just a matter of how we popularise that amongst brain tumour patients.
And can I just add briefly, I think this whole space of not just cognitive rehabilitation, but rehab as it relates to brain tumours, patients and carers really we really need to sort of push that space, because, you know, as Jake has said, really the nihilism is evaporating, and we really need to come to this space where, not as he hinted at, it may not be that we can reverse the change, but we can mitigate the decline, and we can actually maintain the function that people actually have. And so I think that is as much a benefit to me as actually, you know, we accept we can't go back to our old normal, but with our new normal that we can actually maintain that and have the most optimal quality of life. So I think this whole rehab space, as it relates to brain tumours, really needs to be stronger, and more research and just access to the skilled workforce that can really help patients.
Thanks, Lorna. Look, without divulging an individual's deficit, I'm a mother of a brain cancer patient. Well, he's a very fortunate survivor. And I'd have to say what Nicola is suggesting is absolutely fantastic. I've complained recently to whoever will listen, just how, including Helen sitting up there, just how dreadful it can be. I'm sorry to all those people who are patients here today, but we've been on a long journey too. We are lucky survivors, our family, but it is very, very difficult sometimes, and I think what Nicola is proposing sounds absolutely fantastic, and I'll be seeing her the minute this is over. Thank you. Sorry, that was a statement, not a question.
Are there any more questions from the floor?
Thank you. I know we're talking today about treatment and surgery and all those wonderful things. Is there any research being done on prevention?
Kerry, do you want to speak to that?
It's
Sorry, it's 21 minutes till lunch, so if you
right.
Is that going to be long enough?
Okay, now let's just take it one step. Prevention is difficult to look at prevention when we don't know the cause. So I think that's the number one point I want to make. So looking at the cause, what does cause a brain tumour? And Lisa Chalmers is in the audience at the moment. She's the coordinator of what we call AGOG epidemiology. Now, AGOG epidemiology is operating out of every state in Australia. And what that is is a very comprehensive survey that we're giving patients and their carers, as well as asking for a blood sample. Now, this comprehensive survey is asking every single question possible that we can think of. We can do that survey. Awesome, fantastic. But, you know, we're opening up the box as wide as we can to try and work out what are the causes. And I think that's one of the things that we haven't done well in the past. A lot of clinicians will ask you, what's the immediate cancer history, if you get that question. But no one actually asks, what is the history of mental illness in your family? What is the history of dementia? What is the history of depression in your family? Are these actually related to what the cause of a brain tumour is? So if we haven't asked that question, we can't get those answers. And I think now is the time where we're actually starting to find some answers. There's an amazing group at UCSF in San Francisco, and they've got a cohort of around about 10,000 patients where they're asking those questions and looking at what could actually be causing a brain tumour. And they've come up with some fantastic revelations for particularly oligodendrogliomas where there's a mutation in TERT. Now, TERT is a gene that's involved in cell survival, and TERT is actually involved in Alzheimer's disease. So with Alzheimer's disease, that the TERT's not working, so you end up with your memory cells dying really quickly. In cancer, the opposite happens, so you've got too much TERT, and so the cell just keeps dividing and surviving along the way. So that's one huge breakthrough that's only come in the last 2 years, that we actually possibly know what causes an oligodendroglioma. Now, that goes to prevention, okay? So that if we can do tests earlier on, perhaps we can have early detection of an oligodendroglioma. Now, I think something that Jacob will attest to, and a lot of the clinicians as well, is MRI screening is not the solution to prevention of a brain tumour. Blood testing, could that be a tool for prevention of a brain tumour? And again, we need to know what the causes are first before we can look at prevention. Diet, I'm probably the worst one to say, but stress is probably related to cancer. But how do you control stress? I've got no idea. If someone can tell me that, that'd be great. We all hear about exercise, healthy living, balance, and I'm not a clinician by any rate, but the word balance is so spot on. Not too much, not too little. Big advocate for a glass of wine's very good every night. So it's all in balance.
It's actually 3 or 4 nights a week with 3 alcohol-free nights, but just it's fine.
So does that answer your question to a point?
Anyone else on the panel want to comment on that? Helen, do you want to comment on some of your observations of... Okay, that's a no.
A deficiency of vitamin D, is that something, B12, I sort of feel that brain function and that vitamin go together?
Yeah, there's no evidence for B12. And again, with AGOG epidemiology, we've got the blood samples there, so we can test for that and actually convincingly show, anecdotally, is there a link? And I think that's the problem at the moment, is that everything's anecdotal. So...
The B12 does sort of go stop some stress.
Yeah. Does a clinician want to... I'd say yes, but...
Again, that's the value of these epidemiological studies, because you're posing a question, and the only way to answer that question is by asking as many questions as we can and finding out if it truly is associated. So you're asking the right question, we're getting the right information, touch wood.
In the front here.
Just a quick follow-on question in just regards to demographics and incidence. Because we're all involved in, brain tumour support, are we just seeing more of it because we are involved with it? Does the actual incidence of brain tumours in adults and children in paediatrics, is it increased over time, or are we just being more aware of it?
Someone here from the Cancer Council, but the last time I looked, we're seeing more cases of brain tumours in Australia, but one of the problems is we're all living longer. The incidence of high-grade malignancy is increasing in the elderly. Everyone argues is what is old, so that is really over 65s. The incidence of benign tumours in children is increasing, so that may or may not be linked, but there's not many 2-year-olds kind of carrying mobiles around. So the question about mobiles is still up for grabs. We are doing more MRI scans, and I get so cranky when everyone that comes in with a neurological deficit to my ER at 90 years age. I mean, I was late this morning because I had to go to handover, and Granddad arrived at 90, and I mean, he'd been in a nursing home, but he had a neurological deficit, and the pork chop of the registrar did a flipping MRI on the poor bucket. I mean, excuse me, but I mean, I was, look, I mean, even getting the poor fella to lie still in under the scanner was so inappropriate and waste of resources, it wasn't funny. Because if I'd found something, what the dickens was I going to do about it, I mean, he needed pain relief for his fractured rib. I mean, the overall incidence of brain tumours is increasing in Australia on the basis that we're all getting older. The incidence of benign tumours in children is increasing, but the actual age-weighted rate of malignant brain tumours doesn't seem to be increasing. But what we are seeing is that we are doing much better in peripheral tumours, breast cancer, lung cancer, melanoma, and they're all turning up in the brain and they don't know what to do with them. Blood-brain barrier. So their drugs are working really well from neck down, and we're getting calls now because the metastases are arriving in the brain, and some of their new drugs are working really well. And the last barrier.
Is convection enhanced delivery, anything like that, being done here in Australia, where it's actually a mechanical infusion directly into tumour in the brain?
Not that I'm aware of. We did have a trial maybe 10 years ago. We were sticking in some stuff where people, what that is you have your brain tumour removed and you leave a cavity and you have these little, like an IV pole hanging out, and you walk around the ward having this stuff infused over a week. And it's under pressure, so it's meant to go out where the spider web is wandering. But it's lost a lot of popularity. It didn't seem to work. It didn't seem to go where it was meant to go, and the drugs that we were putting in didn't seem to be as efficacious. I'm not sure if anyone's doing Glidel still. Is anyone doing Glidel? What they did was they cut it out and then they put these wafers around the cavity on the idea that it would leach out to where it was meant to go. I mean, there are a few centres in Australia that still like that idea. We did a few and then ended up taking everyone back to theatre to remove them because they cause seizures and infection. So we gave up on that pretty quickly. I mean, the idea is really great. It's one place. You take a lump out of a breast, you can't kind of stick something in the hole and hope that it'll diffuse out where the wanderers might be. So it's a very tempting idea, but you just don't seem to be able to deliver it, even if you stick something in or whatever.
I think that's an interesting point, though, in terms of the situation which Helen was describing, where we may have a systemically active and effective agent that just can't get into the brain. It's a very, very interesting thought.
Just really quickly, because I've got a lot of respect for clinicians, what are you finding most frustrating about brain tumours, benign or malignant?
I'm going to get really personal. People who want to take care of patients, I'm just kind of... The patients need a lot of care. It's not just about writing a prescription. It's actually about who is going to administer the prescription, who's going to pick it up from the chemist, who's going to make sure they take their anticonvulsants, who's going to make sure that they get to their radiotherapy on time. And you know, these patients just don't need a doctor. And the young kids coming through my clinic want to leave at 4:30 in the afternoon, and they, you know, don't want to care, you know, take care of the DVTs, infection, the psychosis, the X, Ys and Zs, and the CAS, you know, if one more CAS doctor injects steroids into my patient when they arrive, when I've just spent the last 4 months withdrawing, I'm going to kill them. So these patients are very complicated. As far as they're going, you know, breast, melanoma is a flavour of the month. And we just need a whole lot more dedication in the medical sphere. GPs need more education. They're really rare. You can't expect your GP to do all this stuff. And we need dedicated nurses who know this stuff that will be on the end of the phone 24/7 to take the calls. Because that's my frustration.
I think that was a very good point that Jacob made in his talk. This is a disease. It's not just about the patient. It's always the patient and their family. You know, you get your license taken away. You can't drive. You know, so many things that you do day in and day out can become difficult.
So I'm a neurosurgeon. I'm at the acute phase, and I will give you my frustration. It's coordination, coordination, coordination. Okay, we've got patients. We effectively hand them off from surgeon to radiation oncologist to medical oncologist, and then there's a surveillance period. But the coordination, as Helen has just said, is the thing that falls through time after time. And neurosurgeons are terrible at coordinating things. Medical like poor Helen, she's got no time to. Have you got any time in your life at the moment? Sue, likewise. Doctors, unfortunately, are generally very bad at the logistical side of coordination. At Prince of Wales, we've had a clinical nurse consultant who's been a care coordinator. Unfortunately, that position's fallen through a little bit at the moment, but yeah, but she has been fantastic, okay, because she stepped up to the role of trying to own patients' day-to-day, not management, that's not the right word, but coordination. Access to MRIs, access to the appropriate specialist, what to do about the steroids, what to do about driving. And my frustration, time after time, coordination.
So who do I go and see, Mr. Baird?
Absolutely. Mary Foley, Department of Health, all of them.
Is it internally the Prince of Wales, or is it something else?
It's everywhere. It's everywhere. So I don't get riled up very easily. I will get riled up about coordination.
Because they text in the email saying, oh, so-and-so's leaving, so-and-so's back, a new one in January, and then nothing. Yes.
On this New South Wales Oncology Group Committee that we actually all participate in, it's one of the main issues that we've been discussing for a long time, and we are all frustrated with it. You know, it's one of those things that I think it's interesting by comparison that Helen talked a lot about the complications that brain tumour patients have. In North America, the neuro-oncologists are neurologists who've then developed an interest in the oncology of brain tumours, whereas here Helen's a clinical oncologist who, you know, learn about all sorts of cancers and then focus their attention on neuro-oncology. I think it's, even across the world, we can't decide who are the best sort of doctors to do the neuro-oncology side of things, and let alone, you know, and then that flows on with the care coordinator side of things. A lot of the models are that there will be general care coordinators that will do some brain, but also some breast and bowel and prostate and things like that. All of which have, and I think that brain cancers have such a unique set of complications and things that we really do need the expertise. This is where we do suffer because of the numbers, but the amount of time that each patient would take with a care coordinator from a breast cancer patient versus a brain cancer patient is astronomically difficult. So all I can do is reassure you all and reassure my colleagues as best I can is that this is an issue that, you know, we're not prepared to let go away.
Are we still talking about frustrations?
Yeah, go for it.
Where do I start? I'll be brief. So, look, care coordination, absolutely. I think for this entire state, as it currently stands, I think there's one FTE for the entire state, I think, and it's just changed this year. So it'd be wonderful, dare I say, anything about breast cancer today, but a sort of a McGrath model for brain cancer and brain tumours. And we've advocated, decade more, and it's this tension between who's going to pay for it, who's going to resource it. Potentially. Potentially, yeah. I would just add that one of my frustrations is community placement for young people with brain tumours. So when they're in their 30s, 40s, 50s, and they're deemed too young for a nursing home where the age cutoff might be 70 or 75, and just, trying to advocate for these patients and families to find quality high-level care, and just because they're young, doesn't mean they're any less deserving of the care an older person would have. So I think that would be one of our key challenges as well.
Well, I used to... research and funding. No, I used to be really frustrated. But I'd have to say that's changed in the last 5 years. And, as Jacob said in one of his last slides, there's hope. And I think that's the best thing that's going on at the moment is for patients, when you get into that hole of recurrence, what happens next? There's actually hope. There's a lot of great stuff coming up, and if you stay around for my talk, you'll hear about all the amazing things that are going to be available very soon. So I think this is such an exciting time for you all, and there's hope. We can beat this disease. We can.